So first up, we have a wonderful colleague of mine and a warm and lovely human being, Dr. Christopher Stauffer. Chris is an associate professor of psychiatry at OHSU, which is Oregon Health and Science University. That's right behind me up on the hill. Chris's work with veterans in the Portland VA is remarkable, and they're going to share their work today with us regarding everything that's been happening in the last year. Chris, welcome.
So everything Roz Watts just said. Yeah, thank you for being an inspiration, and thank you for speaking to the sometimes impossible tensions that we feel trying to work within these old systems. And I think what I'm experiencing now as sort of the newer generation of psychedelic scientists within these systems is, I love a mycelial metaphor, but I feel like it's like the mycelium has entered into the system and is eating away at sort of the dead stuff that we don't need anymore to make room for new growth. So I really feel like that's the case. I have been tasked with going through the last year of science to give an overview of clinical trials, pivotal clinical trial work, and then sort of looking into the future of what's important. So first, just looking at our history of psychedelics within the Western medical science literature. So this is a chart of the number of PubMed results by year. And PubMed is a database that's run by NIH, the National Library of Medicine, that holds all of the sort of biomedical, bioscience literature. So you can see it goes all the way back to the 40s. This was before psychedelic was a word, before MDMA or psilocybin entered into our consciousness. And back in the 40s was LSD, and mescaline was in the scientific literature a little bit. And you see an uptick in the late 50s with an increase in LSD research, psilocybin. And then you see around 1970 there was sort of a peak and then a drop, and we all know that was the Controlled Substances Act. Classic psychedelics became Schedule I substances. 1985, MDMA became a Schedule I substance, and you see this sort of dark era in the scientific literature, although we know that there was a lot going on underground that we later were able to translate. And in 2000, that's when Johns Hopkins started their program. Roland Griffiths, Bob Jesse, who's here. And so you see, again, an uptick in the scientific literature. And then just in the past few years, you see this exponential increase. And there was a time not too long ago, like 5 years or so, where I was able to easily track every important clinical trial happening. And I knew the researchers, and we have far surpassed that at this point. So it's been interesting putting this together just because it's really hard to keep track of everything going on. One pivotal thing that happened in the past year is the FDA released draft guidance for psychedelic clinical trials. And they also received a lot of feedback, mostly about sort of who's able to do this within a clinical trial. But this is guidance. It's not necessarily meant to be law, and I think the intention from the FDA is actually to help all of these companies entering the space and trying to move different psychedelics through the FDA drug development process, making sure that they're spending their time and their money wisely in a way that the FDA will then take them seriously and consider their applications. So I've spent the last few years with one foot in the Portland VA, clinical trials that are overseen by the FDA. I have a DEA Schedule I license, so a lot of regulation, a lot of oversight, and one foot in the Oregon Psilocybin Advisory Board. And at first it felt like that tension was a bit too much, but then I started to sort of notice that it's not a binary, that there's a lot of overlap, there's a lot of shades of gray. And just looking at all these different categories, they're just different perspectives. And I really do believe, and I've heard this echoed on the stage yesterday as well, that these are not competing models, that all of these models can exist simultaneously. And I think having all of these models, maybe not toxic, but all the other models give access to different populations, support each other in different ways. And so we'll be focusing this talk on the medical model. So FDA-guided clinical trials, potential FDA approval. This work is done in diagnosed patients, so usually there's an indication, clinical indication. It's typically done with at least one licensed clinician, and there's a psychotherapeutic framework. I think some of my words got cut off there too, but for anyone who is not familiar with the FDA drug development process, there are 3 main phases before the FDA will decide on whether or not an intervention is FDA approved. Phase 1 looks at healthy individuals and just tests the general safety. A lot of times it's dose-finding studies. Phase 2 looks at the intervention specifically in people with some sort of clinical indication, so MDMA-assisted therapy for PTSD. And these are smaller pilot trials looking at safety and then kind of preliminary efficacy. And then phase 3 are usually multi-site trials with a lot more people and randomized controlled. There's usually a placebo control. And then once phase 3 has completed, then you can submit a new drug application to the FDA and they'll decide whether or not to approve it. I'm going to offer citations and some resources, so I'm going to go through the next few slides pretty quickly, but you can always look up the resources if you want additional information. So this is the second MAPS phase 3 trial. This was published this past year. MDMA versus placebo-assisted therapy for PTSD. This is the protocol, a series of prep visits, and then 3 treatment cycles that involve 1 MDMA session and 3 integration sessions afterward. And each treatment cycle is approximately a month. And then there's blue triangles. The blue triangles are PTSD assessments, so assessing PTSD symptoms, and that was their primary clinical outcome. And you see that mapped out here. And there was clinically significant improvement in drop in PTSD symptoms between the people who got placebo or therapy only versus the people who got MDMA. And I personally had concerns about this one because this phase 3 trial basically started when COVID kicked off. And so people were trying to do MDMA-assisted psychotherapy with masks and face shields and social distancing. And so I was really concerned that it would affect the results, but these results look just as good, if not better, than the first phase 3 trial. And so now MAPS has completed their phase 3 trials that they've agreed on with the FDA prior in their special protocol assessment. And they will be submitting their new drug application in a couple of weeks. And the FDA hopefully will review that and get back to them by second quarter of next year. And then if they do approve MDMA-assisted therapy for PTSD, the DEA has 1 month to deschedule MDMA. And so we may have legally FDA-approved MDMA-assisted therapy by like fall of next year. This was another pivotal paper that was published last year. This was by USONA, Psilocybin-assisted therapy for major depressive disorder, and their active placebo was niacin, which causes a flushing response. So phase 2, this was published in the Journal of the American Medical Association, and it's the largest phase 2 randomized controlled trial to date for major depressive disorder. USONA is another nonprofit research company. I'm sure most of you know this. And this was their protocol. It's a lot to look at, but essentially it was a handful of preparation sessions, 1 psilocybin session, 25 milligrams, and then a few integration sessions. So just 1 medicine session. And this was the result. So you can see, again, there was a significant difference in reduction in depression symptoms between the placebo and the psilocybin arm. And so now USONA is moving into phase 3. They're planning to start phase 3 studies for this early 2024. And then this was Compass's phase 2 study, which was also published in this past year. So they're using Comp 360, which is their patented formulation of psilocybin. And they had dose-tiered studies. So they had 1 milligram, which essentially served as an active control, 10 milligrams and 25 milligrams. And they also had one dosing session. And this was for treatment-resistant depression. So usually that's defined as failing 2 treatments or not being helped by 2 treatments prior to this. And so here is the result of that. And there were significant reductions in depression symptoms at week 3 when you compare the 1 milligram to the 25 milligram. And so Compass started their phase 3 trial like 2 weeks ago. So they're moving into phase 3. And then I started trying to do literature searches and trying to find where these other drugs were in the FDA process. And it started to get to be a lot. And so I reached out to Josh Hardman, who runs Psychedelic Alpha. And I said, hey, I have to turn these slides in. Do you have like an image or a figure that I could use? And this is what he sent me. So those are all of the drug companies moving these interventions through the FDA drug development process. And this has not been updated since last December. And so I would say if you want to keep tabs on this sort of thing, Psychedelic Alpha is a really great resource. You can, every month they release an update in the science, and pretty soon they'll have an annual review of the year in review, which will probably be a lot more helpful than this. But I think the thing that I'm most interested in is thinking beyond drug development. So we're so focused on how to get these things FDA approved, but there are so many questions that we still need to answer, and just questions that I think will help the field in general. I think moving beyond diagnosis, which is, the medical model is beholden to as far as like getting something FDA approved. But I did a study with Brian Anderson at UCSF, psilocybin-assisted group therapy for long-term AIDS survivors. And when we were working with that population, it just it didn't feel quite right to apply a diagnosis as the eligibility criteria. And so we looked at demoralization, which is like a sense of hopelessness, helplessness. It's a measure that's often used in cancer patients. And so we used that as our eligibility criteria rather than PTSD or major depressive disorder, which can also be kind of pathologizing to the individual. So moving beyond diagnoses, or even including multiple diagnoses, which is more real world, where you see people with PTSD and depression and a substance use disorder. Which moves into doing more pragmatic studies in more real world settings, doing studies on implementation, more diverse samples, studying the psychotherapeutic framework. So we're doing a study right now of MDMA-assisted group therapy, looking at different aspects of the set and setting, music, tree therapy, practical questions like what medications do people need to taper, and then looking at this kind of age-old question that we can never find an answer to, of finding an adequate placebo and blinding. And I will pass it off to Adi to introduce Manesh. Thanks.
Thank you so much. Thanks, Chris. I wanted to remind everyone that for all of the questions that I know you're dying to ask Chris, there is the Slido app that you can use to submit your questions. If you see a question that is similar to yours, go ahead and use that little button to thumbs it up and vote so that while we're up here, we can prioritize the questions that have the most consensus interest. If you need a little bit of help downloading that app, there's some QRs at the back table at the back of the room. So we're really, really looking forward to answering your questions in our panel discussion. Next up, I'd like to welcome Manesh Girn, who's a postdoctoral scholar at the University of California, San Francisco. Manesh.
Awesome. Thank you, Eddie. And yeah, big thanks for Kevin and the team for inviting me. It's a huge honor to be speaking right now. So I was asked to cover the major questions, perspectives, and findings in psychedelic neuroscience that emerged over this past year. And I have 10 minutes to do so I'll do my best here. And I realized that a lot of people in this room probably aren't neuroscientists, so I'm taking more of a didactic approach with this, trying to define things and make it as clear as possible. And hopefully I succeed in this. How do I use this clicker? Okay. So by way of moving into this, in this talk I'm going to be going over some of the main findings and using them to illustrate the questions behind them and contextualizing them. But high level first, what are the core themes? And so one theme in neuroscience research with psychedelics is their cellular mechanisms and how that relates to things like neuroplasticity. So we've all heard of the serotonin 2A receptor that psychedelics seem to activate in order to elicit their subjective effects and potentially also their therapeutic and neuroplastic effects. I say potentially because some of the findings this year have kind of started to call that into question. And a major overarching thing that researchers are investigating right now in relation to the cellular mechanisms is how much can we differentiate or dissociate the processes that relate to the subjective experience, the psychedelic experience, versus the neuroplastic changes in neurons versus the therapeutic benefits we're seeing in the clinical trials. To what extent are these based in different mechanisms and pathways in terms of neurons, and can we develop drugs that tap into one or the other? And second, I'm a neuroimaging researcher, so I have to mention some neuroimaging. Human neuroimaging is interesting because we can get a window into the brain activity changes underlying the acute experience, as well as the therapeutic benefits we're seeing in clinical trials. Something I should have mentioned for the cellular mechanisms and neuroplasticity, that's almost exclusively work in rodents or in vitro in cells in a dish. It's very hard to do that research in humans, mainly because you can't cut open their brain and stain it like you can do with a rodent. Human neuroimaging is a way to look at brain function related to psychedelics in humans. And another application of neuroimaging is translational, because we have these findings in rodents that are emerging, increased dendritic growth, increased neuroplasticity, etc. And then the question is, how can we actually look at these things in humans? Because a lot of the inferences we make, basically all of them, on how neuroplasticity is relevant for psychedelic effects are based in studies not in humans. And so with neuroimaging, there's a lot of active work ongoing, trying to find ways to develop proxy measures which are, can be used as a substitute for the neuroplastic investigations that are done in rodents, and that we can then link to clinical outcomes. So these are the three major themes, and I'm going to walk through a whole bunch of studies here, exploring some of the questions that have come up this past year. So this one, which was published in probably the top scientific journal out there, Science, was motivated by this question of why does serotonin, when it activates the serotonin 2A receptor, not induce the same neuroplastic effects that psychedelics do? Presumably the serotonin 2A receptor exists for serotonin because that's the main endogenous chemical for it, but why doesn't it induce these effects that psychedelics do? And this study looked at something called location bias. So does the location of the receptors matter? And in particular, it's known that some serotonin 2A receptors are inside of the neuron, not on the outside like most receptors. And so then they asked the question, do psychedelics get into the cell? Do they actually affect these intracellular receptors? And turns out they do. So psychedelics such as LSD, psilocybin, DMT, 5-MeO-DMT, these compounds are able, because of something called lipophilicity, so their ability to move through the cell membrane, go into the cell and activate these receptors. And serotonin can't do that. And so this study found that some of the unique neuroplastic effects and maybe even the subjective effects of psychedelics are due to their ability to move into the cell membrane and activate these intracellular serotonin 2A receptor. And just an aside, it's interesting that serotonin can't get in there, so the question is, outside of psychedelics, why do we have these receptors in the cell that serotonin can't get to? And that leads to all sorts of fun speculations around endogenous psychedelics, potentially the endogenous creation of DMT, or other metabolites of serotonin which we're able to get in there. But, I just talked a lot about the serotonin 2A receptor, and this is what we talk about all the time, but then there was this big finding published in Nature Neuroscience which really challenges that and basically turns a lot of what we knew on its head, because this study found that they were able to block the serotonin 2A receptor and still get neuroplastic effects and therapeutic effects in rodent models. So then the question is, okay, are we wrong about the serotonin 2A receptor? Is there something else going on here? And in this study, they found that psychedelics also bind to something called the TRKB, or TrkB receptor. And this receptor is really essential for neuroplasticity, outside of psychedelics in general. And usually something called brain-derived neurotrophic factor binds to this receptor to initiate the changes we see in dendrites and neurons associated with neuroplasticity. And in this study, they found that independent of the serotonin 2A effects, psychedelics, in this case, I believe they studied LSD, bind to this receptor and amplify its ability to be activated by BDNF. So it's able to amplify ongoing neuroplastic activity in the brain, again, independent of the serotonin 2A receptor and potentially independent of the psychedelic experience. And so this kind of shows that maybe the idea of non-psychedelic serotonin 2A agonist drugs or non-psychedelic psychedelics could be possible and relevant for therapy, because now maybe there is activating this, helping amplify, not activate, this TrkB receptor. And adding to the mix here, it was this great paper also published in Nature Neuroscience, finding that psychedelics open something called a social critical period. Basically, rodents can only learn to associate certain areas with positive social interactions early in their adolescence, and then afterwards they lose the ability to do this. And if you give them a psychedelic, whether it's LSD, psilocybin, but also ketamine, ibogaine, and MDMA, it seems to reopen this window of plasticity where they're able to learn behaviors they're usually not able to learn after adolescence. And moreover, this was due to how psychedelics amplify their sensitivity to neuroplasticity in something called metaplasticity. And so this suggests that there might be other critical periods or aspects of brain plasticity that are usually closed in adulthood that might be able to be opened in humans. And something else really interesting about this finding, and actually the one with the TrkB receptor, is that they suggest that psychedelics amplify plasticity that's already occurring, right? So then you immediately can think of context effects, integration practices, and ongoing psychotherapeutic support. It basically provides some mechanistic support for the idea that these things are important because they could synergize with psychedelics. Psychedelics essentially might make the brain more plastic in response to these other adjunctive interventions. And of course, this is a major theme because there's a lot of theoretical pieces out there questioning how important is psychotherapy really, how much integration do we really need, can we just give the drug and minimize everything else? But these two major hard-hitting studies do provide some mechanistic evidence of why integration, adjunctive psychotherapy, adjunctive interventions can be synergistic with the psychedelic experience and the effect to potentially enhance outcomes and their longevity. And along the theme of non-psychedelic psychedelics or non-hallucinogenic psychedelics, don't like the word hallucinogenic because it's quite myopic and inaccurate. I think many of us can agree, but in this study they found that an analog of LSD, a slight molecular change on LSD, was able to, in rodents, induce neuroplasticity and induce quote-unquote therapeutic effects without inducing a psychedelic experience, which means for them they weren't twitching their head in the way we associate with psychedelics. So this suggests potentially, there are compounds that can do this, that can induce plasticity and therapeutic benefits without inducing a trip. What was interesting in this paper is that these effects were blocked by a serotonin 2A receptor antagonist. And that flies in the face of that TrkB stuff, the TrkB paper, which didn't find that. And it just suggests how complex these things are and how dependent some of these results might be on particular experimental paradigms and procedures. So it's not a clear story at all. And switching to ketamine, ketamine is also extremely complex and multifaceted in how it affects the brain. We still don't quite know what is the central mechanism underlying its antidepressant effects. and why it lasts so long even though it doesn't last so long in the brain. And so this study found that ketamine seems to become trapped within the receptor. It blocks the NMDA receptor in a way that extends its ability to block the activity in something called the lateral habenula. So this interesting area has been called the disappointment center in the brain and is overactive in people with depression. So the question in the study was like, how is this region blocked for a full 24 hours, even though ketamine is cleared from the body and the brain much before that? And they found that it's being trapped inside of the receptor in a way that other similar drugs aren't. And this might also relate to why ketamine is effective as an antidepressant, where other drugs that are pharmacologically similar, like memantine, are not. And so here's a unique mechanism related to how long it's staying at the receptor. And something interesting about this is we usually associate ketamine's benefits with neuroplasticity, but this is actually independent of plasticity. And so it suggests that at least within the first 24 hours, ketamine can be inducing antidepressant effects independent of neuroplastic boosts, like boosts in neuroplasticity. Again, suggesting the complexity of these mechanisms and their basis in multiple receptors and multiple interactions with the receptors, and similar to serotonergic psychedelics. And so you can just see how this is all complex, and we're really just in the process of understanding these things. Okay, and so switching into human neuroimaging, the first ever brain imaging study in humans with DMT was published this past year by my friend and collaborator, Chris Timmerman. And they found that the effects were actually quite similar to LSD and psilocybin, but just stronger in the effect size. The brain became much more interconnected, more entropic in its activity over time. And in particular, they found that regions in our transmodal cortex, such as our default mode network, lead the charge in becoming the most connected with the rest of the brain. And so there seems to be this more globally connected mode of brain function driven by these regions such as the default mode network. And they found this with intravenous DMT. And another one, another paper, another good friend of mine, Parker Singleton, who looked at brain changes after MDMA therapy, after the MAPS, patients who did the MDMA for PTSD study looking at brain changes, and they found a number of things, but the main thing was that two regions of the brain, which are usually relatively less connected in people with PTSD, were then normalized, and these two regions are the hippocampus and the amygdala. So the hippocampus is involved in memory, remembering our past experience, but also contextualizing our experiences. And amygdala, as many of us know, fear, emotional processing. And so the brain findings that he found after the MDMA treatment for PTSD in these patients was that there might be a greater integration between memory, contextual information, and fear memories, potentially restoring the balance rather than having extreme decontextualized emotions. Lastly, here's a little interesting paper because I wanted to find an example of a translational study. And so this study was in humans with EEG to measure electrical activity in the brain. And they found that as compared to psilocybin, EEG responses to this auditory stimulus in the theta frequency band were higher, and this correlated with antidepressant effects. And so this is interesting because this was 2 weeks after a psilocybin experience. They had increased responsiveness to this. And this is kind of a marker of sustained neuroplastic change. These neurons, even 2 weeks later, long after the drug is gone from the body, were more responsive to stimuli, and this was correlated with reductions in depression symptoms. And so this is translational because it's a marker of neuroplastic change available in humans that might correspond to some of the neuroplastic changes we're seeing in rodents, and provide some evidence in humans that these neuroplastic changes actually are relevant to outcomes, as a lot of us do think they are. Okay, that's all I had for this, so thanks so much for your attention.
Thank you so much, Manesh. I am also a translational neuroscientist, so I may be one of the only ones in the room who is like, A bunch of our audience members are really interested in the similarities, differences, risks, benefits, or otherwise concerns that you have about synthetic psilocybin as it's moving through the FDA clinical trials versus botanically or fungus-derived psilocybin experiences or products. So if you could each take a little moment to talk about those, compare them and contrast them and your concerns, risks, benefits.
I suppose I could speak to that first. Yeah, as you know, with synthetic psilocybin, it's much more precise. We know exactly what we're getting. We know the quality of it. And I guess the argument for the botanical product, the actual mushroom, is that there might be a synergistic effect. There might be other compounds in the mushroom that could potentially amplify or change the subjective effects and maybe change other secondary effects. But really, there is no evidence of that yet in the literature, and there have been studies which have tried to look at the pharmacological activity of different metabolites, things like baeocystin, arugacin, and other compounds. And there are a lot of researchers in the field, like such as Dave Nichols at Purdue University, who just really think the entourage effect is not a thing with psychedelics. But that said, there's still more research to be done. It is quite under-researched, surprisingly, but it's also quite difficult to do these things. My personal belief is that it really depends on the strain of mushrooms. And I feel like certain strains of mushrooms contain something called beta-carbolines, and these are monoamine oxidase inhibitors, and they might allow other compounds to be active, which are usually not in the mushroom. And so there is some potential there, but we run into issues, again, because of the imprecision in knowing psilocybin content, how it varies across different strains and even different mushrooms of a given strain. And so it is something that's very difficult to bring into a medical context, for sure.
And I would add cost. So I think, one benefit of Oregon mushrooms are really cheap to grow. I think we've added a little bit of cost because we have to test them. But compared to a pharmaceutical company and some of the price increases that go on there, and Sue Sisley, I think, is speaking later today. So I think the DEA has a hard time with anything that's organic because it's hard to get specific doses. But Sue's working on some exciting things, and I'll let her tell you about them.
Mm-hmm. Yeah, I mean, most of my background is in cannabis, and so we see this, very similar thing, although we have an FDA-approved cannabinoid, Marinol or dronabinol, and it has its indications, and it is prescribed. There's also, all this wild chemistry that comes from the plant. And you're right that this sort of entourage effect or these polypharmacy effects that are happening with naturally derived products, they do induce a lot of noise. They introduce a lot of variability into the system. One thing that I often think about is that there can be a place for both, right? That there are certain patients who need to be prescribed an FDA-approved medication, but then there also should be the flexibility for these naturally derived products for the people who might benefit from them. Yeah. One thing our audience is really curious about is for lay people who are not involved in research or not affiliated with an academic institution, how do they become involved in research?
I think participating in studies, especially survey studies, there are a lot of survey studies that are trying to crowdsource data collection from the public, which are really important for the progression of the field and for things like developing questionnaires and these kinds of things. And so, being aware of trying to tune into the different online sources of being in touch with these kinds of studies and devoting, your time towards it can be really helpful. And also, I think, part of what can draw more attention to it and potentially more money into the space, a lot of the research is based on philanthropic money still, is spreading awareness, hosting local events, and supporting in these other indirect ways too.
Yeah, I agree with participating in research and also referring people and educating people. I think we get a lot of participants who are like, I don't know about this, but I have a few friends who said I should come apply for this study. And so I think, through word of mouth, we get our studies done.
Yeah, that's great advice. We have a lot of folks who are interested in this question, which I might actually hold for a later session because we have an entire panel about research that's happening in Oregon. But I did want to acknowledge that there are a lot of people in the room who are very interested in how Oregon licensed facilitators and service centers can contribute to the research. Do you have any brief thoughts about that?
Do you want to go first for this one?
Well, I know you're going to talk about that later.
I'm going to talk about that extensively.
I can comment. I think, I mean, as scientists, we want data, right? And data collection is so important. And yeah, these organ services and other clinics and all the rest are huge opportunities for massive data collection. And there really is a data problem in psychedelic research because these trials are so expensive. And only, a lot of them are 20 to 30 people, some larger ones coming out now, but still on the order of 100 is not nearly as enough, which you need to really get a sense of the population level effects and this kinds of things. So I think for facilitators is, really what I want to see is some kind of centralized place people can go to where here are some standardized measures that are commonly used and that would be amazing to collect so then we can compare across different sites. I think standardization is the main thing. So getting a sense of these are the important psychological questionnaires and measures that researchers are interested in, and here are like standardized ways to deliver them so then we can collate across all these different facilitators and sites to create something that's actually meaningful. I think that would be huge.
That resonates a lot. That's exactly what we're doing.
Wonderful.
I think briefly before we move on, I think that from my perspective, just planting the seed early in the day, the most important thing that licensed facilitators and service centers and most importantly training centers can do is instilling the value of research, right? If we have a collective culture that is involved in the sacred process of research, I think that that's something that we can just plant and let it grow naturally. Let's see. Some folks are really interested in knowing about the interaction between SSRIs and psilocybin. So we know that a lot of folks were using SSRIs prior to being recruited for these trials. They most likely went through some kind of tapering or weaning process. So from your perspective, how do the SSRIs and these folks in these clinical trials, what's happening there?
We don't have a lot of great data. Hopkins published, maybe this was last year, Hopkins published a big survey study that showed, this was like kind of self-report and retrospective. So people were basically saying like, I was on an SSRI, this much before I took a psilocybin, or had a psilocybin session. And I think, maybe you know this, but I think the window is like 3 to 6 months of off the SSRI before it doesn't affect the psilocybin anymore. But I'm sure that it varies widely and depends on how long they're on the medication, a lot of different things. Compass researchers also published a study last year looking at people who received their psilocybin and were on SSRIs. And I think their conclusion was that it didn't really affect the psilocybin experience.
That's really promising, I think, because if you think about that duration of time that a person doesn't have their normal, daily medication and, kind of the rebound that they might experience from being off of their medications, they're operating from a totally different baseline when they're going into the trial. So thinking about like doing less harm as these, research participants are coming into it. From a neurobiological perspective, based on your understanding of the SSRIs and the, serotonin receptors, what do you think's happening?
Yeah, I think particularly with chronic use, there's some evidence of like reduced, psychological experiences with psychedelics, and which makes a lot of sense because one of the things that happens with chronic SSRI use is your serotonin receptors get downregulated, right? Because although it's kind of controversial now, the idea is that SSRIs increase serotonin activity in the brain, and the brain is always trying to maintain homeostasis, right? So if there's an increased proportion of activity, it's going to down-regulate the receptors to try to get some balance. And so if you have less serotonin 2A receptors, you're going to have less of an effect. And so I think in a lot of cases with these chronic users, it's a case of dose finding, like personalized dose finding, because the usual dosage ranges might not apply to them. But also there's mixed findings on shorter term use. In that Compass study you mentioned, I believe they also found that with shorter term use, there wasn't a reduction, but there was a reduction in things like anxiety. So it even potentially improve the safety profile with shorter term use. And so there's an interesting complex interaction depending on how long you used it, likely your dosage too, and all the rest.
Yeah. And sort of speaking of duration, one of the things that's happening with some of these pharmaceutical trials is, moving toward therapies that have a shorter duration of action, right? So we know that one of the things that's contributing to the cost of psilocybin services in Oregon is the duration which the drugs last. That's a long time for a facilitator or two to be in the room with a client. So I'm curious to hear, like, based on your, reading the literature or, seeing preliminary data for some of these other compounds that are shorter acting, is there any evidence, or do you have any sense that those shorter acting compounds are leading to better or similar clinical benefits?
When we're thinking of something like 5-MeO-DMT, which is shorter, like 20, 30 minutes, the research is much earlier, and so we don't know for clinical indications in sort of this specific framework. But there's hope, and actually one of the companies that's developing psilocybin is now starting to develop 5-MeO-DMT, and I think it'll be a while before we have like head-to-head comparisons, but that'll be interesting to see.
Mm-hmm. Yeah.
Yeah, on the neurobiological side, what was interesting is, well, some questions were, if 5-MeO-DMT, for example, lasts, like, it's such a short molecule in its effects, short subjective effects, are the neuroplastic changes going to last as long? And there was actually one study this past year, maybe 2 years, I'm not sure when it's published, but they found that there were persisting neuroplastic changes 30 days later after this. What really is like a 15-minute to 10-minute, 15-minute experience a lot of the time. And so that does suggest there are changes that last despite the short duration. And so, yeah, we definitely need a lot more research. And I know there are companies and research groups actively looking at 5-MeO-DMT. So I do find that to be very exciting, for sure.
Yeah, that's wonderful. Well, we'd like to thank you both for sharing all this work with us today. There's some really exciting work happening in the field, so please join me in thanking our guests.
Thank you.